So now I'll talk about, these are statements I took directly out of letters that were written by the CRA to my clients or to other practitioners' clients that they forwarded to me saying, are you seeing this? And I'm saying, yeah, unfortunately, I'm seeing the same thing of what you're seeing. And they say, quote, we've determined that the specified wages claim for so-and-so, okay, were not directly undertaken by the taxpayer, nor was it for work taken on behalf of the taxpayer. So I'm saying, well, okay, fair enough. They're quoting the Act. They're saying words directly undertaken. And when I took the in-depth tax course 20 years ago, they said, well, the way you deal with the Act, if there's a definition, first you look in the Act. It's directly undertaken, a term defined in the Act. Well, no, I couldn't find it defined in the Act. But we'll talk about what you do then. So then you take what they call a normal definition or a common definition. What does the words directly undertaken mean to the average person? What would Webster's dictionary, what would Oxford say? And you interpret it with no hidden meaning, what that would really mean to an average person. Okay? Directly undertaken. But we'll come back to that. So just to give an overview, to put some perspective of what I'm talking about here, is, and what is undertaken anyways, whether it's direct or indirect, what's happening here? So what happens is, you now have two sources of income for a lot of specialists. And this is what's getting confused here. You have Dr. X, who often is a professor at a university or teaching hospital, and Dr. X, the individual, on their T1 return gets $100,000 or $120,000 salary as a professor. Okay? And they're supposed to do research and supervise things and whatever. And they report that on their personal tax return, and they pay tax on that and whatever. Okay? Dr. X works at the university usually 1 to 3 days a week, and then the other days of the week up to 7 days a week, it seems, because these guys put in a lot of time, they spend in their what they call a medical professional practice, which is a separate corporation. It files its own tax returns. It's a separate tax person under the Act. There's the individual that files a T1, and then there's this artificial tax person called a corporation that files a T2. That corporation, for the services of the doctor, receives OHIP payments and AFP payments in the corporation for the work that it does, for dealing with its patients and whatever. And often in the hospitals, the AFP payments will be packaged to say, you know what, we'll take 30% or some larger number, and we'll do all your admin, we'll do your bookkeeping, we'll collect all your fees for you. You just do medicine. We'll do all the business side. We'll take care of all that. We'll pack it in your fee. So government's saying, well, all that, if you can't break it out, it's all R&D then. If the chance that even 1% of that could be R&D, it's all R&D, unless you can break it out. Okay? So what kind of work do they do? So what happens is these guys are almost all part of teams. They don't do research by themselves. They're part of a team of 10 or 20 or hundreds of doctors around the world, or a local team that partners with other teams, and they're doing international cutting-edge research. There's no argument that what they're doing is SR&D. Now, in their medical professional practice, what kind of work are they doing? They're testing their hypothesis. They're saying, well, I'm part of this team, and when I'm dealing with my patients, I'm testing. Is this work? Is this protocol correct? Is this what we're doing? And we respond back, and we adapt and update the protocol. So it's arguably that they're participant in actually setting the protocols, the design of the test, the experimentation itself, all the data gathering and collection, which are all activities specifically allowed under the income tax under the definition of SR&ED. Engineering, design, operations research, mathematical analysis, computer programming, data collection, and testing. And they're doing all of those things. Maybe not the computer programming part, but maybe they have someone doing that part too. And anyways, all of them are aimed at both their own projects, which I would argue they're entitled to exploit, and maybe the projects of the group. So, where does that lead us? So as I said, the definition of SR&ED in the Act says SR&ED includes engineering, design, all these things, data collection and testing, which is what the doctors are doing in their medical practices related to their projects that they're arguably an integral part of. Okay. So what the Act actually says, so the CRA has a quote, what the Act says is there may be deducted, so Section 37, expenditures on SR&ED related to the business of the taxpayer carried on in Canada and directly undertaken by the taxpayer. They're focusing on this and saying, well, you're not directly undertaking the research by testing your patients and updating the protocols of your group based on the analysis that you find and the observations that you make. So, well, that doesn't seem right to me. It seems like it couldn't be any more directly undertaken than that, but there's a legal question, so I have to look at what is the definition of directly undertaken. And as I said, in the Act, there's no definition of directly undertaken that I can find in the Canadian Income Tax Act. So now I go to CRA documents, and I don't find directly undertaken defined in there either. But I did find a term called directly engaged. And what I'll say is, well, I think it's reasonable to say, well, maybe they meant directly undertaken, but they use a different term. So in the letters, they meant to use the term directly engaged. I'll give them the benefit of the doubt. So if we assume that they just used the wrong term in the letter they wrote to the client, but they really meant directly engaged, they say directly engaged in SR&D is based on the tax, not the job title of the employee. I couldn't agree more. It refers to hands-on work in paragraphs A to D of the definition of SR&D. We just talked about that, right? Paragraph D. Right? Engineering, design, operations research, mathematical analysis, data collection, testing. So they're doing all of those things. Generally, employees, including managers, supervisors, conducting experiments and analysis and performance of basic research, etc., are considered to be directly engaged. So again, I'm saying based on what I understand the doctors are doing, they appear to be directly engaged. Is it directly related? I would argue yes, if it's directly engaged, it's directly related because we don't have a definition of directly related, and I'm arguing directly engaged would be synonymous with that. All right, so I've mentioned this. One of the key points is it's only the wages paid by the medical professional practice to the doctor that are being claimed. So the doctor, for their academic activities, was paid personally by the university or the hospital, but that didn't go into the medical practice. So again, what we'll propose is the CRA in its proposal is mixing a lot of those. One other key concept that was eliminated when the CRA released its policy papers in 2012, so they got rid of all the ITs and all the ICs and all the examples and everything else that was published about SR&D, and they put in these new papers. And one of the things I said, hey, this is missing. The CRA said, well, there's no change whatsoever in policy. All the policies are the same. This just streamlines our policy. And I said, well, this particular comment is missing here, and I think this could lead to problems. And I raised that to people in Ottawa, and they said, no, this will never be a problem. This couldn't be an issue, right? And I think it's a huge issue now that I don't talk to any current CRA reviewers in the last 3 to 4 years who understand this concept at all, which is entitlement to exploit. And what you need to claim SR&D credits is entitlement to exploit. All right? So what does that mean? They're saying, well, the doctor may have to share the rights with the hospital or whatever. Does that mean they're not entitled to exploit? Entitlement to exploit used to mean, and I would argue it still does if there's been no policy change, but maybe there has been a policy change. Entitlement to exploit says, is met in cases where the taxpayer has the right to use a patent that results from the SR&D, even if the taxpayer is charged a royalty. Also considered to be met in cases where the taxpayer is entitled to distribute and market any product. Basically, has been granted any preferential right to use the product whatsoever that Joe off the street wouldn't have. Then you're entitled to exploit. There's actually a part of the form that says, did you do work in collaboration with anyone else? It actually envisions that people might do R&D together, cooperatively, to collaborate to develop stuff. So these are all envisioned, and all of them are entitled to exploit this. Okay? So again, I'm not sure necessarily what the CRA's intentions are on this, but there's a couple things that they appear to be applying the income of one legal entity to another, saying, well, you've got a contract with the hospital, so you're not allowed to exploit that in your medical practice, anything that you do. That's not the case. And they're trying to apply income of an individual to the work of a corporation. So there's a mismatch there. Here's another statement that I saw in the proposal to my client. And I'm reading it, and it says, the doctor being a member of Department X is receiving X dollars of academic funding from the government of Ontario, as well as receiving Y dollars of surgical repair funding. Okay? These amounts are considered government assistance. So I'm saying not only all AFP funding, of which maybe 1% is R&D, is being considered, but surgical repair funding that has arguably nothing to do with R&D is now being considered R&D. So again, I'm looking at all this and I'm saying, well, this is written by the police officers, CRA, who are supposed to enforce the law, but they appear to be making their own laws. So what happened was, of course, I go to Ottawa and I say, is there anything, about this? And this appears to be a local initiative. So this is started just in the Toronto to Hamilton regions, and each district is trying to develop its own rules to apply or propose to taxpayers, but they're not equivocal across Canada. And I have a big issue with that, so we'll talk about that. Okay. So what the Act says, the legislation, is for it to be government assistance, it has to be reasonably considered, as I said, in respect of the SR&ED. And my argument is the current CRA position does not appear reasonable to me. Okay? Here's what Ontario Ministry of Health says this model, the AFP or APP models, are designed to do. They say that that there's a variety of models for physicians that are specialists because we can't, they have other factors that are different than a general practitioner, and it's hard to just say amount per patient. So they have several, most agreements are blended models with several remuneration methods. I'm telling you, every hospital, every group has its own, and they're different. Like, there's some similarities, but there's so many differences. So they look at global funding based on services and locations, base payment for teaching, research, admin, indirect services, premium payments, bed utilization rates, sectional payments on fee-for-service billings. So it's not just R&D, okay? Some of the models are used to cover specific communities for unsupervised, that are under-serviced by specialists, departments in a single hospital, full-time specialists at health centers, province-wide gynecology, oncology, radiation, emergency services in hospitals, 24-hour availability of high-level care. I haven't said R&D. This is what the AFP's payments are for. I haven't said R&D yet, and yet 100% of this is being considered R&D. Okay? Academic, health centers, education, and research. Okay, so I have the word research as the second last point. Services such as psychiatry, surgical networks, neurosurgery, and anesthetics in northern regions. So all of this, CRA is saying is all R&D if you can't provide the breakdown. And the Act says it's got to be reasonable. So I'm saying, well, they're using a weakness of the hospitals, not reporting how small that is because it's probably insignificant, and turning it into an issue where they're saying a medical doctor, because we have a system that limits how much medical doctors can charge, unlike the United States, should be limited in claiming SR&ED. Because unlike their American counterparts who could charge the patient directly, because we put the government in the middle to administer their fees, they should not be allowed to claim SR&ED credits. And I don't find anything in the Act or anywhere that would support that position, and yet it's actually being rolled out and discussed directly with claimants, not with practitioners, not with people in Ottawa who should have some say in it, who are our policy providers. It's literally being put into force as we speak.